It. Recording the cloud.
Ron?
Yeah, I'm here.
עופרה, אנחנו מנסים... אוקיי, ביי.
אתה גם על הדסה?
רון, אתה שומע אותנו?
כן.
Ron?
Yeah,
Hey.
I'm here.
So you are going to introduce everyone.
Yeah.
Like you're going to say, obviously I'm chief resident and welcome to this evening, and you're the MC for everything, okay?
Yeah.
Okay, great.
הנה, אלי התחבר.
I think we can start, right? Okay, so good evening, everybody. My name is Ron Kaufman. I'm the chief resident at Hadassah Hospital and the fellow and a glaucoma fellow. And I want to welcome you tonight for the update talks in ophthalmology of Hadassah Hospital. We have a very interesting night for you today. We have two topics that we're going to talk about today: neuro-ophthalmology. We're going to start with the neuro-ophthalmology part, and afterwards we're going to move on to glaucoma. In each session, we're going to have two talks. The first one will be given by Dr. Ari Sheremesh and Dr. Josh Kruger, and afterwards we're going to move to the glaucoma, which is going to be given by Dr. Gabi Greifner and Dr. Yaniv Barkana. So we have a really special night for you, and I really hope that you're going to enjoy. We're going to give you an overview of a few topics, and we're going to give you an in-depth view on others. So during these talks, you are more than welcome to send questions in the Q&A, because we have a time for discussion after each talk. So please send your messages through the Q&A, and we'll try to answer them after the lectures. So let's start with the first talk by Dr. Ari Shemesh. Dr. Ari Shemesh is a neurologist and a neuro-ophthalmologist at the neuro-ophthalmology service at Hadassah. Please, Dr. Shemesh.
Thank you. Hi, can you see my screen?
Yeah, we see
The presentation mode.
Yeah, not in presentation mode. Yeah, perfect.
Now, yes, in presentation mode?
Yeah, now we see it well. Thank you.
Okay. Okay, so this is a case of a patient with a super hearing in the Glaucoma and Neuro-ophthalmology clinic. Okay, so a 60-year-old woman complained that a loud noise can cause her a sensation that the world is tumbling or bobbing up and down. Straining at times could cause the same phenomena. Another disturbing symptom was hearing my eye movements. Symptoms were first noticed 2 years ago. So this is her exam. So nothing to mention about the afferent system. So visual acuity was 20/20 both eyes, normal color vision, no RAPD, eyelids, slit lamp examination, and the related fundus exam was normal. Examination of her eye movements. So I specifically wrote everything that was examined. So range of eye movements, including alignment, was normal, convergence was normal, straight ahead fixation was steady, eccentric fixation was steady, saccades were promptly initiated, accurate, and of normal speed. Optokinetic responses were normal. VOR, slow phase, and fast VOR was also normal. So the question is, do you think that the exam was unremarkable? So the answer is not yet. So with video oculography and removal of visual fixation, there was no spontaneous nystagmus. However, there was torsional downbeating nystagmus towards the right ear with a pinch nose valsalva and also Tullio phenomena. So when I say Tullio phenomenon, I mean that with loud noise, with headphones, she had the same torsion downbeat nystagmus. So let's see eye movements. This is a video. And you can see, and you will see it in slow motion in a second, that there is a downbeat. This is mixed downbeat and torsional nystagmus towards the right ear. So if she looks to the right, there is more downbeat component. And when she looks to the left, there is more torsional component. Hearing to finger rub was abnormal. It was decreased on the right. And the patient had a positive malleolus sign. And positive malleolus sign means that when a fork was held on the malleolus, she heard the vibration in the right ear. So the question is, we have a patient that describes that she can hear eye movements, but when she was examined with, for example, with hearing to finger rub, she had decreased hearing. So can someone has decreased hearing and super hearing that he can hear his eye movements? So this is pure tone audiogram. And what you can see is two things. One is a conductive low frequency hearing loss. This is the right ear, what you see here. And what you also see, and if you can see, this is 0, 0, this is normal population. So you can see that the patient, when the stimulus was put on her bone, she had, this is -10. -10 means that she has super hearing, bone conduction hearing on the right side. So she has conductive hearing loss on the right, but when the stimulus was put on her bone, it was not just normal hearing, it was much, much better hearing. And this phenomenon explains why she can hear eye movements. So the diagnosis is superior canal dehiscence syndrome, and I will talk about this diagnosis. Superior canal dehiscence syndrome is caused by an abnormal thinness or incomplete closure between the uppermost semicircular canal in the upper part of the inner ear and the brain. And you can see the illustration on the right. This condition can cause hearing loss, sound distortion, vertigo, dizziness. And the vertigo and dizziness are distorted by, triggered by loud noises, by changes in the pressure in the middle ear, for example, by inserting a wet finger, or changes in the intracranial pressure by sneezing, coughing, heavy lifting. Symptoms may appear spontaneously or after a trauma. So we know that in the inner ears, there are the semicircular canals, which are our sensor for head rotation. And in rare instances, during fetal development, the uppermost bony semicircular canal fails to close or thicken normally. So for normal hearing and balance, we have to have this canal to be a closed passageway, which means that sounds coming on one hand, which is the oval window, and out of the other, which is called the round window. But if there is this area of opening in the bony canal, sound can leak. And this is the reason, because sound can leak. This is why they have a hearing loss. And because this opening, there is also transmission of bone conduction sound. And this is the reason why these patients can hear internal sounds. So this is CT imaging to show you that the upper part of the superior canal or the anterior canal, this is the same canal, is abnormal. So the symptoms, as I said, sound vibration, escape the normally closed system of the inner ear and activate the hair cells. And activation of the hair cells cause rotation. Loud noise. This is how loud noise can cause dizziness. Coughing, sneezing can cause the same phenomenon. And why? So if the pink area here is the brain, so any change in the ICP will also change the fluid dynamics in the canal, and this will cause abnormal fluid and therefore abnormal sensation of head rotation. So patients will usually complain of autophony. So what is autophony? So autophony is hearing one's self. So we all can hear some sounds, internal sounds. However, patients who have autophony can hear very different sounds of their breathing, heartbeat, blood flow, and even the slight movements of their eyes. And this is because this opening in the bony semicircular canal, which is called the third opening. So for example, pulsatile tinnitus. So if patients doing an exercise and the blood pressure gets higher, so we all have pulsation of the dura, but fortunately, because the temporal bone is the thickest part of our skull, we don't hear it. But patients who have superior canal dehiscence can hear pulsatile tinnitus from pulsation of the dura. When they speak, some of them can hear their voice with some echoing. And this can be very overwhelming loud for them. And some of the patients will start to whisper just because of that. So what nystagmus would you like to see in order to diagnose this disease? So it really depends on what maneuvers are you going to apply. So if you will, so with Valsalva against pinched nostrils, which means blowing the nose, you will cause excitatory stimuli to the superior semicircular canal. And this will cause a downbeat torsional nystagmus. Another maneuver is to just take a wet finger and insert it to the patient external auditory canal. So the positive pressure should also cause downbeat nystagmus. A third option is with loud sound. However, you can also examine with inhibitory stimuli to look for inhibitory nystagmus, which will be upbeat torsional. This will be with Valsalva, but this time Valsalva with a closed glottis. You're asking the patient to strain, for example. Another option with the wet finger, this time if you examine with a positive pressure, then you take out your wet finger from the external auditory canal, and this time with negative pressure, you can cause a upbeat torsional nystagmus. And these drawings try to explain why different maneuvers will present with different nystagmus direction. So the basic mechanism is what is the direction of the fluid in the anterior or superior semicircular canal. So with positive pressure here in the middle ear cavity, there will be ampulofugal movement of the fluid, and this will cause excitation of that canal. And what we are seeing as downbeat nystagmus, this is of course the first phase of the VR nystagmus. However, if the ICP increases, for example, with a closed glottis valsalva, this will cause ampulopital movement of the fluid in the superior semicircular canal. And this is the reason why there will be torsional upbeat nystagmus. So what is the differential diagnosis? So much more common patients who will have, that will tell you that with valsalva they get some dizziness. So you should think about vasovagal presyncope, for example, situational presyncope. Even Chiari malformation can cause symptoms of dizziness with valsalva. So the way to differentiate is two things. Just with superior canal dehiscence, there is triggering by loud sound or middle ear pressure. So with Chiari or vasovagal presyncope, loud sound or middle ear changes in middle ear pressure will not trigger any dizziness. Superior canal dehiscence versus vestibular migraine. So some patients with vestibular migraine, which is very common diagnosis in clinical practice, they will say that they have what we call phonophobia, and this will be co-occurred with the dizziness. So just with patients with superior canal dehiscence, the vertigo is time-locked to the sound. Patients with vestibular migraine, even if they will say that they had some dizziness following hearing a loud noise, the effect will last much longer than the sound itself. What is the differential diagnosis for vertigo dizziness lasting seconds to minutes? So the most common diagnosis is BPPV, which of course is triggered by head movements. Another diagnosis that can cause symptoms for seconds to minutes is vestibular paroxysmia. It could be spontaneously occurred or can be provoked by exercise or head movements. Usually it will occur many times per day. And disorder with transient visual symptoms of blurriness that can last for seconds is a superior oblique myokemia. And we usually diagnose this with we need a slit lamp in order to look for it, because this is a very subtle eye movement. Okay. So what is the treatment? So treatment for superior canal dehiscence is surgical. The surgeon will plug the canal to eliminate most of the fluid movement. He can resurface the canal also. And if patients are properly selected for the surgery, they generally find a relief of their hearing and balance symptoms. Okay, so that's all. If you have any questions, I'll be happy to answer.
Thank you, Dr. Shemesh, for this great talk and this really rare and interesting topic. We already have a few questions. So the first one is, could you explain, please, why the nystagmus could be either a downbeat or upbeat?
Yes. Yes. So we have in each inner ear, we have 3 semicircular canals, and there is fluid within every semicircular canal. The way that the semicircular canal detects head rotation depends on the direction of the fluid. So when we rotate our head in specific direction, there is, because of inertia, there is movement also of the fluid. And the fluid pushes the cupula, and then the cupula transmits that there is head rotation to the brain. So, and this is what I'm going to say specifically for the anterior semicircular canal, but it also true for the posterior semicircular canal. So for the vertical semicircular canals, the direction of fluid that causes excitation is ampulofugal, which means that the fluids flows away from the cupula. And just saying, this is the opposite with the horizontal semicircular canal. So if there is ampulofugal fluid of this anterior semicircular canal, this means for the brain that there is rotation in the plane of the superior superior semicircular canal. So with different maneuvers, there are changes in the direction of the fluid within superior canal dehiscence syndrome. So it really depends from where is the pressure. If the pressure comes from the middle ear cavity, like for example, inserting a wet finger, so this will cause ampulofugal fluid movement, and this will cause excitation. So excitation of anterior or superior semicircular canal will present with torsional downbeat nystagmus. So, however, on the contrary, if there is a high ICP, for example, with Valsalva, so the opposite will occur. There will be shift of fluid towards the cupula. And this with the superior semicircular canal will cause inhibition of this semicircular canal. Any inhibition of semicircular canal means excitatory of the antagonist semicircular canal, and this will cause a torsional upbeat nystagmus.
Okay, great, thank you. If you have any more questions, of course, you can send them either in the Q&A or in the chat. Another question that has risen is can the diagnosis be made only by CT imaging?
No, this is a good question. So I'll just show you the CT, just a second. So this CT is with reconstruction, and it is known that if this is done not with the right protocol, so many patients could have something that looks like that they have superior canal dehiscence, and this is related to how the CT machine interprets the change between the bone, which is very high density, to the brain, and sometimes it can look like there is dehiscence. So it really depends on the protocol, and the protocol should be, so the finding with the right CT protocol, the finding is just supporting. However, for diagnosis to be made, you have to have the clinical things and the audiometry findings and some vestibular tests that I didn't talk about, which there are a specific neurophysiological test. The name is VEMPS that can be supportive. But based on CT scan alone, one cannot make the diagnosis.
Another question that was sent was, doesn't the surgery should cause vertigo or imbalance if the canal is plugged?
Okay, so this is another great question. So it is true that after the surgery, so in the surgery, the surgeon will plug the canal. So after the surgery, the patient will have a dizziness for a couple of weeks. However, the brain can adapt for it. And this is a really good example of adaptation of the brain for transient symptoms. The brain cannot adapt. So every time the patient has a excitation of the canal, he will feel dizziness. And of course, there are all the auditory problems of the orthophony that we talked about. So after the surgery, the patient will have deficit of his VOR. However, because of this deficit is constant, the brain can compensate. And because with a good surgery, there is a resolution of the orthophony, and orthophony is really bothersome for the patient. So patients are satisfied with the surgery. But this is correct that during the first at least 4 to 5 weeks following the surgery, the patients will have some continuous imbalance.
Okay, great. So if we don't have any other questions, no, I don't think so. So thank you, Dr. Shemesh. That was great. We're gonna move to the next talk by Dr. Josh Kruger. Dr. Kruger is the head of the neuro-ophthalmology service at Hadassah Hospital. He's gonna give us a talk about strabismus surgery for complex gaze deviation. So please, Dr. Kruger.
Hi, good evening. Thank you very much to Dr. Shemesh for a wonderful presentation. We're so glad to have him on board our staff now. And all clinicians should feel welcome to refer their patients with dizziness or nystagmus, acquired nystagmus, to see him for assessment. So I'd like to present to you a case that I recently encountered that I think is good for teaching at all levels, whether it's to residents just in terms of assessments of a complex neuro-ophthalmology patient. And I hope that it has something also for clinicians just to understand the importance of a proper neuro-ophthalmology assessment for all patients who have neurological disorders, no matter how difficult the case seems to be. So here's our story. Okay, so this is a 24-year-old male who presents 3 years prior. He had a tragic gunshot wound to his head. And the injury left him severely debilitated, with profound right-sided weakness of his arms and his legs. He's wheelchair-bound, inability to verbally communicate, inability to properly feed himself. He requires a PEG and requires 24-hour caregiver. And he's been going since the time of the injury for years now, extensive rehabilitation. And thankfully, I think someone thought to refer him for a formal neuro-ophthalmology assessment. This is just one sample image of the brain. This is a CT scan, an axial CT scan. There's some tilting in it. And we see, for those of you who are not so regular to look at imaging, I'll just remind you that right is left and left is right. So we see on the left side of his brain extensive bone loss. We see profound damage to the left hemisphere, particularly anteriorly, where while we see ventricles that are rather slit-like on the right side, we don't see them on the left. We see evidence of midline shift, speaking to the severity of the injury. I've done my best the patient's family has given permission to publish their photos, but asked to restrict them as much as possible to their eyes. So this is a zoom of a photo that was taken. And what's meant to show you this just is the way that he normally is as a default position. And we see from the angulation of his nose that he adopts a marked face turned to his left, and that the eyes are also deviated to the left side. Here in this video, I'm asking him, I'm trying to get the eyes to look to his right. I've given him a target to look to his right, and the left eye certainly can't cross the midline at all. The right eye can barely for a moment cross the midline, but immediately there's a tremendous tone to bring the eyes back to the left position. We just see that again here. In terms of his vision, obviously it's extremely challenging to assess his vision. He is unable to verbally communicate and has a tremendous amount of difficulty even cooperating. What I do see is I'm able to establish that there's optokinetic nystagmus in both eyes, which suggests that vision should be better than 6/120 at least. I'm able to establish that he can at least pursue a target somewhat to the left and to the right, though with severe impairments. And again, as I said, neither eye really can get past the midline. The video I showed you, the right eye momentarily broke past the midline. There's absolutely no vertical movement. And he has a complete lack of awareness of any stimuli in his right hemifield for each eye, suggesting that there's a complete right homonymous hemianopia. And based on the CT, it's not surprising. We understand that there's been severe damage to his left hemisphere. Here in a photo that was taken up closer, I was able to kind of get him to, this is not his normal eye position where I was able to get him to look to his extreme right. We can at least see evidence of left ptosis. We see that there's also a left exotropia and a little bit of a hypotropia if you look at the cornea light reflex. In terms of the pupils, we see that the left pupil is dilated, but in terms of just assessment, if we're starting off the right pupil, the size is normal, but it's very sluggish to reactivity. The left pupil has a fixed and dilated situation. And in terms of assessing for an RAPD, because the left pupil is not responding, I need to assess by using a reverse RAPD test. And what it actually shows is that it seems that there's a right RAPD. And throughout the course of the encounter, well, we'll get to it, but despite the more profound limitations that we seem to see at the surface here, he seems to also be fixating primarily with the left eye. And here's one of the reasons that it seems to be the case, that we see this very marked torsional nystagmus that's in the right eye alone. In terms of the globes, it's unremarkable except for the fact that both optic discs have clear borders and notable pallor. And so overall at this point, the impression of the findings is that we have severe trauma that's provoked a bilateral optic neuropathy that seems, at least based on the right RAPD, the reverse RAPD, to be more in the right than the left. There is a right homonymous hemianopia, a profound deviation of the eyes to the left, and a profound inability to look to their rights. There's a vertical gaze palsy also. I can't get him to look up or down with any sort of maneuver. We have this asymmetric right eye rotatory nystagmus, and as I'm sure you guessed by now, evidence of a left third nerve palsy. So here's what concerns me the most about his situation. And as you know, the topic of this seminar was doing strabismus surgery for this patient, and here was the rationale. Here we obviously have a normal setup. We're looking at the eyes from above here, and we see the a visual field for each eye. In his case, because of his situation, he has a profound right homonymous hemianopia, and that means that now this would be the visual field that he has, but he also has this profound deviation of his eyes to his left. And that means that what we're seeing in the cones is really, under normal circumstances, what his visual awareness is, meaning he's really only aware of what's to his extreme left and what's kind of almost behind him. Not only is he not aware of what's to his right, he's really not even aware in this current situation of what's directly in front of him. And that's what most concerns me about him, that he has an inability to interact with his visual surroundings and an inability to verbally communicate what's going on. In fact, when I give him a target and very, very slowly ask him to engage in a target that I bring directly in front of him, which is quite challenging, you can see based on the position of his nose that he has to very slowly adopt a severe head turn to his right, which he's really unable to sustain. He's only able to do it momentarily. This is the head position that he needs to adopt in order to engage what's going on in front of him, if he knows that there's something in front of him. This is when I took a stimulus, brought it into his visual field to his extreme left, and slowly brought it over that I could get to follow me. And so based on this, the goal, the reason that strabismus surgery was done was to turn the eyes to his right side to increase his visual awareness of what's in front of him at the very least, and hopefully maybe allow him to be able to engage even what's to his right side. And this case that I'm presenting to you is unbelievably unique, but there is precedent for this in literature to support the fact that this sort of surgery can be done for gaze deviations. And it's what's basically based on the principle of doing a Kestenbaum procedure, just the same way that we would do a Kestenbaum procedure for infantile nystagmus to shift the direction of the eyes. That's what can be done here under these very unique neurological patients. What was very important for me, I think, in terms of planning strabismus surgery was the question of, can we achieve binocular alignment here? And I want to explain why with this case I thought that that needed to be put to the side and that could not be the goal right now. We know that the eyes have tremendous asymmetry between them. The left side has a third nerve palsy that's causing multiple vectors of misalignment. The right eye has this asymmetric, unique rotatory nystagmus, and there's a communication barrier. So that even in situations where we have regular strabismus cases, one of the things that repeatedly we see is that the eyes to the examiner can look like they're aligned, but if they're slightly off, we might not notice it, and yet it can cause the patient severe visual symptoms, especially when there's elements of rotatory misalignment that we might have a lot of difficulty appreciating. I just want to give you an example of what I mean. So here, let's pretend that our patient is being asked to look at a cat in front of them. And this is my estimation of what he would see. We would have here a situation, because he has an exotropia, that's going to generate a crossed diplopia. Because of the left hypotropia, the right eye image will be, again, crossed and down to the right, and there'll be this element of a torsional nystagmus or torsional oscillopsia that's in the picture. This is maybe what he would be experiencing with the eyes misaligned. But if I now go ahead and do my best to align the eyes, even if they might look perfectly aligned to me, here's my concern, that to me, the eyes are going to look like they're pointing the same direction, but he's going to have tremendous visual confusion because of a slight residual misalignment and the rotatory nystagmus. And that's why I feel that I have to resist the usual temptation of trying to plan surgery to align the eyes, and rather each eye really needs to be a separate project, with the idea moving forward that we're really going to have to think about a monovision strategy for him, meaning we're going to do our best to achieve a status where each eye hopefully is able to better engage the surroundings. And we're going to see after the surgery which eye he prefers, and he'll hopefully have two options that are available to him. Maybe for different circumstances, he might use the right or to the left, but we want to give him the most options possible. So that's one of the major decisions that's made here. And regarding decisions about the surgery, I'm very blessed to very frequently be able to operate with Karen Handler. Karen Handler is a wonderful pediatric ophthalmologist who also has a lot of experience in adult strabismus. And certainly this was a case where I definitely wanted Karen by my side in the operating room, and we put a lot of time into discussing various surgical options and trying to put together a plan that we would hope would help the patients. And so here was the plan after a lot of discussions that we came up with, realizing that probably no plan was perfect, but at least this is what we were going to try from the outset. So for the right eye, it was more straightforward that what we wanted to do in order to turn the right eye to the right side, we were going to try to release the medial rectus as much as possible to do a maximal medial rectus recession, and to tighten the lateral rectus as much as possible with a maximal lateral rectus resection. The left eye, because of the third nerve palsy, was much more challenging situation. We obviously want to do a maximal lateral rectus recession. We don't want to go overboard. We still want to allow him to be able to move the eye. In an extreme case, we could do something like an extirpation, but we don't want to restrict his movement too much. So we're going to do the maximum recession that we think we can achieve. The problem is, whereas with we can't really, the medial rectus resection, we want to tighten, we want to increase the adducting tone, but he has a third nerve palsy, and we're really not sure how much, if at all, we can gain from doing a strengthening procedure on the medial rectus. In a normal patient, or in other situations, I can do testing like force generation tests, or I can sometimes engage the patient to see if they're able to really adduct past the midline. But in his case, there's a lot of uncertainty about what he's actually able to do. We know that it's severely impaired, we just don't know how much. So because of the concern about muscle activity of the medial rectus, we have to consider other options that might be out there. And I'll just point out that because of the vertical gaze palsy, we know that the question is, are the vertical recti impaired because of the infracranial weakness to these muscles, or is it a supranuclear element? So other options that are out there that we can employ that are more rare to use would be to use vertical rectus transposition or even an oblique transposition. One of the concerns here is obviously generating anterior segment ischemia. And so we have to be careful with what we do. And that, since we don't have much faith in the medial rectus, we don't want to do a resection, because at that point, we can't really do any more in terms of moving vertical recti. And so what we decide that we're going to opt for is a medial rectus plication, which is an effective way of tightening the muscle that often spares the anterior ciliary arteries. And so here's just a little diagram of what our plan and what we did surgically. So here we have just a left eye under normal circumstances. We're first we're going to go to the lateral rectus, and we're going to recess that as much as we can. In terms of the medial rectus, we said we're going to do a plication to fold the muscle forward and to increase its strength, but to still preserve, hopefully, the blood flow. We're going to take the superior oblique, and we're going to both resect it and transpose it to the medial side to increase its strength and now convert it from a muscle. Obliques normally function as a tertiary function as an AB ductor pulling the eye out, but moving it here now converts it to an AD ductor. And then we want to do something with the superior rectus. We're a little concerned now about the possibility of anterior segment ischemia. So to be cautious, we go to the superior rectus, we divide it, and we resect and transpose the nasal half over to the medial side of the globe to also increase the adducting tone there. And so this is our full surgical plan that we employ with all of the details. And I'm just going to play a surgical video that shows the more unique elements. So particularly in the left eye of the more complex surgery. The other element that we want to put in place is we want to do the surgery with adjustable sutures. Now, adjustable sutures is a great backup when particularly the strabismus, is going to be extremely unpredictable. Most adults are able to cooperate post-operatively with doing an adjustment. We know that that's not going to be possible here. And so coordination is made with our anesthesia team that we might, depending on the outcome, need to bring him back to give him sedation at least to be able to make adjustments. The goal here is going to be to try to shift each eye from extreme left to get it as much to the right and straight. Obviously, our concern going into it is that we could generate too much power and pull the eyes way over to the right. So we want to have this as a backup if needed. So I'm going to show you a surgical video now that focuses on these elements in the lower half of the slide that were more of the unique muscle surgeries that we did. Okay. So we're going to start off now with moving on the left eye. We have an inverted view. I'm sitting from the top. Surgeon sitting from the top, and we're seeing now the isolation of the superior rectus. And we're just dissecting the muscles around it. Now the superior oblique has been hooked on the nasal side. It can be hooked on sometimes the temporal or nasal. We found it on the nasal. Thank you very much to Karen for being the one to successfully isolate it here. We then go ahead and umbricate the muscle and at a distance of about 4 millimeters from its insertion, so to allow for a resection. Next phase was to go ahead to the superior rectus, and I apologize, the video quality here is a little poor, but I'm just taking a small hook and dividing the muscle here. And now I'm inserting a large right grooved hook through the underneath the nasal half of the superior rectus and umbricating the muscle and umbricating it back to allow for a resection. So now we have achieved a resection. Before we go ahead and transpose those muscles, we decided to do our medial rectus plication. So now we've exposed the medial rectus here. We're umbricating the medial rectus at a maximal distance of about 8 millimeters. And now the suture is being passed anterior to the insertion. And now we're going ahead and folding the muscle as the suture is being tightened to bring the muscle up, the folded part up to the insertion. And finally, now we're taking the superior rectus. It's being sutured immediately superior to the superior border of the medial rectus. It's a little hard to see here, but the applicator is just in between the medial rectus and the superior rectus, which has been transposed and sutured. And now the superior oblique, we're bringing over and putting that just beside the nasal half of the superior rectus, also on the medial side here. And you can just see we're just exposing now the transposed superior oblique muscle. So we'll just move back here for a second. So this is post-operatively, we're delighted. We can see he's opening up his eyes. The right eye was looking straight, and even the left eye, there's the ptosis there and he's in pain. But when we open it up, the left eye is also able to look fairly straight ahead. And so thankfully, we're very happy with the outcome. We don't think that any adjustment should be made. And now we're at this point, these are pictures from a month after the surgery. And what we can see here is, you can see this is the right eye, and you watch as the target is brought over to the right. He has great ability now to bring the eye into abduction while still having a lot of preserved adduction. The left eye, there's still limitations, but we're able to move it over into adduction, maybe about 30–40%. So that's also good. One of the pleasant surprises we see is that portional nystagmus is dramatically dampened in his right eye. So at this point, we've had feedback from both the family and the specialists that are taking care of him. And here are the comments that make us so delighted. So the rehabilitation therapist indicates that prior to the surgery, his head and eyes would be turned to the left. And it was actually suspected, and this is one of the points that I want to draw out here, it was suspected that it was due to a neck disorder. And this is why it was so critical, I think, to have the neuro-ophthalmology assessment, because obviously that wasn't what was driving the eyes to the left. It was what was going on that a neuro-ophthalmologist hopefully would understand. Whereas now after the surgery, she's delighted to see that he has a straight head. He's making eye contact with people that are in front of him. He has improved visual field awareness. His eyes have horizontal movements that is much improved. And the pleasant surprise now is he's using his right eye and actually prefers it, which is great because that's the eye that has the maximal mobility. The patient's mother was delighted to update me that surgery, much more than just visual issues, has really had a tremendous effect already on his life, that she sees now he's able to much more coordinated, that his ability to communicate, though still severely impaired, is much better right now. His interpersonal interactions with people is enhanced, and even some tasks that are critical for him, the ability to feed himself, is much more enhanced at this point. Here's just a little anecdote that one of the activities that the mother would try to do with the son is to play Connect 4. It's a popular game. And she explains how it was unbelievably frustrating for him before preoperatively, because she said he used to fill up the left side, that was fine. But when it came to putting the pieces into the right side, he wasn't able to see what was going on. He would just randomly feel around and put the pieces in. And obviously that's unbelievably frustrating. Whereas now he's able to see what's going on to his right and accurately place the pieces in both sides. And for someone of this nature, for the patient, that's a major alleviation of a huge frustration that was in his life. That again, the tragedy here is he probably just wasn't able to communicate what he was experiencing for the past 3 years to anyone. Here's just another anecdote that just emphasizes why it's so important that these patients have an opportunity to have a proper neuro-ophthalmology assessment. So she stated that prior to the surgery, when traveling in the car, he used to keep his head down, and a therapist explained that it's just because he's probably dizzy, and that's the reason why he's keeping his head down. And now after the surgery, she notices that he's able to keep his head up and he looks straight ahead when traveling in the car. So I hope that this is a case that's shown the value of neuro-ophthalmology, where it's not only to function at the level of diagnosis and understanding the nuances of a very complicated case like this, that helps the therapist understand what are the possibilities, but also to plan for a much more enhanced treatment. So again, the take-home messages of the talk that I hope I can leave the audience with is that neuro-ophthalmology is critical, even in these severe cases where unfortunately maybe people for years had presumed that they understood what the limitations were, or that maybe the state of his eyes and his vision was just beyond repair, that it's still critical to undergo a proper neuro-ophthalmology assessment, to have an accurate understanding of what the limitations are and are there opportunities to assist and provide therapeutic interventions. I also just want to point out that while, of course, typically with strabismus surgery, the goal is most commonly that we're trying to realign eyes and provide binocular vision and fusion, that there's other reasons to do strabismus surgery and sometimes to even forego trying to align the eyes. And this is just a dramatic case of where both gaze deviation and a homonymous hemianopia are reasons to really think about moving the eyes to a much more functional place for a patient. If anyone has any questions, I'm delighted to do my best to answer. And if you have any ideas after, please feel free to send me an email whenever you'd like. Thank you very much for your attention.
Thank you, Dr. Kruger, for this really amazing case. And I think that it's really a good example for the importance of a good assessment, and your result is really impressive. Of course, if anybody has questions, yeah, we have a few minutes for discussion, so you can send it through the Q&A or the chat. A question that was sent was, why was there asymmetric nystagmus in this case? Can you try to explain?
Well, I think that it's very challenging to know. And one of the issues here is in terms of where the localization of the pathology is. And in any cases, what we would want is as a detailed MRI to see pathology in the soft tissues of the brain. Unfortunately, because of the injury and the fact that there's likely metallic fragments, that's not possible in his case. I think that the speculation is that when you have particularly an isolated torsional nystagmus, that can be from an injury at the pretectal area, really just for those of us who are not neuro-ophthalmologists, at the top of the midbrain at the intersection of the midbrain and the cerebrum. And that might explain a lot of his deficits. That's an appropriate localization at the top of the midbrain for generating a third nerve palsy, for example, possibly. And damage to one of the supranuclear control centers, the supranuclear, the nucleus of Cajal, is involved in torsional control of the eyes. And so a patient who has an injury can have a torsional nystagmus of both eyes to the affected side. So in his case, damage to his left interstitial nucleus of Cajal would probably cause a rotational nystagmus towards his left shoulder. Now, in the right eye, we're going to see that rotational nystagmus, which is going to be mainly generated, that jerk mechanism, particularly that intorsion, for example, where the eyes are intorting. But in the right eye, where there's so much damage to so many of the recti and other muscles, it's going to at least be hugely dampened. Just even, for example, a jerk that would be an excyclotorsion would be involving the inferior rectus and the inferior oblique. And if you have a third nerve palsy, those are going to be impaired. So that probably there is underlying drive to generate a torsional nystagmus in the left eye, but it can't manifest because of the third nerve palsy.
Okay, great, thank you. But do you think that there are any other therapeutic options that you could have employed in this case, or should be thought about when approaching cases like this?
Yeah, I think it's tremendously important, and this has been explained to the patient, that beyond surgery, that it is absolutely critical that the patient has rehabilitation that really includes very experienced optometrists who have a sensitivity to these sorts of neurological disorders. This isn't the sort of person who should be getting glasses by going to their local optometry shop. Thankfully, we're blessed at Hadassah with wonderful optometrists who have a sensitivity to these sorts of complex cases. And there's all sorts of mechanisms that can be explored. And here I really rely on the experience of our optometrists to think about how they can best address the patient's needs. Just as an example, in his case, it's possible that his accommodative mechanisms might be very impaired, and that someone might think he's 24 years old and not think about it, but the state of his accommodation might be completely impaired, and he might need, in a normal situation, we would say multifocals or bifocals, but because of his impaired eye movements, that's not going to be possible. And maybe a monovision strategy might be something for him more, or separate distance and reading glasses, depending on the task at hand. But again, it's critical that an experienced optometrist is here. By the way, the impaired vertical movements would also be localized to the pretectal area and account for the findings as well.
Okay, great. So I think that we're just in time to conclude this neuro-ophthalmology part. Thank you both for really great presentations of cases that are more rare and more complicated and need more depth of thought. So thank you very much. We're gonna move on to the glaucoma part of this day. We have two great lectures today. The first one is gonna be given by Dr. Gabi Greifner, which is the head of the glaucoma service at Hadassah Hospital. And I think that part of the great thing in glaucoma nowadays is that we have an uprise in multiple options of treatment, and not just the good old trabeculectomy that we had for a long time. And now we have a huge toolbox. So I want to welcome Dr. Greifner to present the updated toolbox for treating glaucoma. Thank you. Your mic is off. You need to unmute the Zoom. Yeah.
Okay, the screen is shared, is okay?
Yeah, it's great.
Okay, so good evening to everyone. I'm so excited to give this talk because the year 2021 was very special to our glaucoma department. And it's not responding. Okay, so there are several aspects that are new. I want to split the lecture to talk about treatment, new treatment and modalities in terms of imaging, medication, and surgery. And first, to talk about imaging. So everyone knows, you know, the OCT RNFL that is thorough use in glaucoma assessment. And here we have an example of the RNFL from the spectralis that in the left eye shows a normal contour of the peaks, and in the right eye shows a thinning change report analysis that can shows us comparison during the years from exam to exam. But this year, we actually started to have the GMPE, or the glaucoma module of the Heidelberg structure. As you can see on the top, we have the regular RNFL thickness that is around the nerve that shows us a normal superior aspect of the nerve and inferior thinning. As you can see, here, it's very nice to see the bundle defect of the RNFL. So the spectralis can do a very nice segmentation of the RNFL, not only around the nerve, but shows us this deficit of the RNFL. And in the picture in the right, we can see the map of the deviation map of the RNFL thickness. And not only the deviation map of the RNFL, but also the segment, the deviation map of the ganglion cells. As we know, the ganglion cells map in the macula is like a bagel. And here you can see absence of some ganglion cells in the inferior temporal aspect of the picture. Ganglion cells deviation map shows this very nicely. More thing that is very interesting is what we call the BMO MRW. The BMO is for the Brooks membrane opening. The Heidelberg spectralis can shows us in every spot the ending of the Brooks membrane. This point where the Brooks membrane ends, we can say that this is the beginning of the real rim of the optic nerve head. And by performing a perpendicular line from this point, the BMO, the Brooks membrane opening, we can draw a perpendicular line, and this thickness actually reflects the actual rim. So by performing this all around the optic nerve, we can draw a map of the real borders of the optic nerve, and we can have a map of the rim, the actual rim of the optic nerve. And lastly, of course, we can have the Hood report, which is a report that we start to use as in every glaucoma patient that actually summarize all what we discussed until now. Here in this window, we can have the RNFL thickness map of the circumpapillary, the thickness around the optic nerve. Here we can have the map of the RNFL and the map of the ganglion cells. And in the right, we can have a map of the flipped image that gives us an illustration how would the visual field look like in this patient. So the absence of the RNFL thickness inferiorly actually demonstrates absence of the superior field. So if we can imagine these patients to have an arcuate scotoma superiorly, that reflects an inferior thinning of the optic nerve. Another modality that we use very common in our department is the CASIA 2 or anterior segment OCT, which is a swept source OCT. I think Hadassah is the only hospital in Israel that possess this TOMI, this CASIA 2, and actually we have now 2 instruments. And here is just example of how to evaluate an angle of a patient after blunt trauma. In the left part, you can see a normal architecture of the angle. In the right side, you can see the angle is a little bit widened. This is an example of angle recession after trauma. This is another example of a patient that have a very thick lens and shows that the iris bombay and very, very narrow angle. In this case, specifically, the patients underwent peripheral iridotomy, and this image demonstrates the patients after the procedure was done. You can see how the iris is very stretched thanks to the pilocarpine effect, and the angle is more open thanks to the iridotomy and this treatment. And that example is an example of a patient that underwent trabeculectomy, and he developed hypotony for several weeks after the procedure. And our hinge was that it's not because of overfiltration, because the bleb was quite shallow. And by performing an CASIA OCT, anterior segment OCT in the posterior part, to look at how the penetration of the OCT is so deep, you can see the fluid accumulates under the ciliary body. So we can use sometimes the CASIA also to demonstrate a ciliary body cleft, like in this example, that can help us to treat, to diagnose the pathology and to treat it properly. Now let's speak about a little bit about medications. As we know, in glaucoma, we can divide the drops that in use to 5. There are 5 groups, and we can divide them to 2 groups. One group is drops that we use to reduce the aqueous production, and the other group is to improve the filtration. And we know that in 2018, a new players surfaced in the world, the Rupresa and the Glanatec, that unfortunately are not approved in the Ministry of Health in Israel, and the latanoprosten or the Visulta, which is an NO and also improves blood flow to the optic nerve. And maybe this is the place to remind all the participants that Glanatec is available in Israel. You don't have to send the patients to the States and to buy this Rupresa in $600, because Hadassah Pharmacy actually managed to buy Glanatec or Ripasudil directly from the Japanese company. And every patient that access the pharmacies, the pharmacy in Hadassah can pay 350 shekels for a bottle and get benefit from the new player in glaucoma medication. And lastly is actually the surgery, which is the most exciting part, which I want to spend a few minutes in the last part of the talk. So just to remind you, unfortunately, the only parameter that is in control in glaucoma is decreasing the pressure. And this can be achieved either by decreasing the aqueous production, by applying some treatment to the ciliary body, or to increase the outflow. Now we know that to increase the outflow from the eye, it can be possessed either by improving the physiological outflow through the trabecular meshwork, what we know now as a MIGS or minimally invasive glaucoma surgery treatments to treat the angle, or to bypass the trabecular meshwork by performing a canal or pathway. And this, of course, all the surgeries that are known that we will take place in a few minutes, in the following minutes. So let's start with the production. As we know, the main player in decreasing aqueous production is the CPC, what is known as the ciliary photocoagulation. Now, in Hadassah, in the last few years, we actually abandoned totally the classic CPC, the continuous wave, and we are using only the micropulse CPC, which is the same energy of 800 and 100 nanometer wavelength. But instead of giving us a continuous wave, we actually treat the eye with a micropulse energy. As you can see here in the small movie, we are performing this procedure using illumination in the left hand that shows us the red reflex, the red illumination, retro illumination. And by doing so, we can localize the area of the ciliary body. So instead, you don't really know where the ciliary body is located. We use this illuminator to localize the ciliary body. And by using this technique, actually, we treated more than 50 patients this year, and almost with zero, or not zero, but almost no aggravated complications. Okay, so now let's speak about other modalities of the glaucoma surgery, the gonio surgery or the MIGS. So you know that in order to improve the aqueous by using gonio manipulations, we can either stent it or cut it. Stenting, I mean by implanting like small devices like the iStent. You can use the solo iStent or the iStent inject, but I want to emphasize with a much more powerful procedure that is called GUT. And this is the time to thank Dr. Belkin from Meir that helped me to start doing this surgery. GUT is for gonioscopic assisted transluminal trabeculotomy. So by performing a direct gonioscopy in the theater, you can see now a very pigmented angle. By the way, the secondary glaucoma, mainly pseudoexfoliation, is it's a very good candidate to this procedure. So the first part is to cut the trabecular meshwork and then to stent this pro-lens suture into the trabecular meshwork. And by performing and continuing pushing this pro-lens into the Schlemm's canal, it can be 180 or 360s. And then in the last step, after pushing this probe, we actually approach to the part when we pull this probe. In a minute, you can see in this specific case, we performed 180 degrees of cannulation, and just pulling this probe, we actually tear the inner wall of the Schlemm's canal. So this is a gonio procedure, quite simple, and no need to deal with the conjunctiva. And until now, we performed several dozens of patients, and there is some learning curve, but we are happy that we adopted this tool as part of our arsenal. And now it's time to speak about the classical surgeries like bypassing the trabeculum. We have to find a way how to bypass the aqueous that is locked inside the anterior chamber. So of course, the classical surgery and the most known part is the trabeculectomy. In trabeculectomy, what we do is simply performing a hole in the sclera, and by doing so, we are allowing the aqueous to go outside the eye and to perform and to create a bleb so this surgery is maybe the oldest one that is done in glaucoma, but we all know that is the complication profile is quite high. So then that's why during the years, many surgeons or many companies try to figure out more surgeries that will be as effective and maybe with a lesser part of complications. Here in Dasa, we are performing many non-penetrating deep sclerectomy surgeries. And I think as far as I know, only 2 centers in Israel perform these surgeries. And so the main difference between trabeculectomy and NPDS is that instead of performing a hole in the sclera, we actually make a deep dissection to the sclera. And as you can see, the dissections involve posteriorly the area of the trabeculum and anteriorly part of the cornea. That's why the membrane that is created in the surgery is called the trabeculodesmatic membrane. So when the surgery is working nicely, the aqueous found itself penetrating this membrane, going out to this lake, to the intrascleral lake, and from there part of the fluid finds its way to the subconjunctival space. These are the steps. These are the steps of the surgery: opening the conjunctiva, performing a flap, making a deep dissection, and exposing a nice view of the TDM of the trabeculomesmatic membrane. The last part in the surgery is peeling the membrane, the inner wall of the Schlemm's canal, and of course, closing the flap. We use viscoelastic material as a spacer, a special viscoelastic material, which is called Hilaflow. This is an example, this nice example of how a patient 3 months after surgery looks like in the anterior segment OCT. We can see very nicely the membrane of the TDM and the space, the black space, which represents actually accumulation of fluid under this flap. And this example shows a very nice filtration with a pressure of 11, 3 months post-op. The first pioneer of the ab-internal surgery was Xen. Xen is an implant that built from collagen that actually acts like a direct pathway that connects the anterior chamber to the subconjunctival space. The Xen that is in use in our department for a few years is actually a very small, a 6 millimeter length of collagen tube, a very tiny tube of just 45 microns internal diameter. This implant is put inside the lumen of a special injector, and the injector is actually put in, is injected through the eye, and this is a short video showing how the Xen ab-interner was performed in our center. You can see the injector now is penetrating the trabecular meshwork, exiting from the sclera towards the subconjunctival space, and in this way the implant is injected outside, and actually by doing so the surgery ends. So Xen was the first ab-interner implant that was introduced to the market, and we here in Dasa were privileged to participate also in an Israeli invention that is really is in evaluation, clinical evaluation here in Israel and in some centers all over Europe, which is called the MIMS. The MIMS is for minimally invasive microsclerotomy. So like Xen, we don't have to deal with opening the conjunctiva, but just introducing the MIMS, but not like the Xen, there is no implant here, but just a driller. It's a cup driller that by introducing into the trabecular meshwork, actually we make a nice tunnel that also connects the anterior chamber to the subconjunctival space, and by doing so, we perform a nice bleb. So this is an example of, we performed only 5 cases the beginning of this year with using MIMS, and by introducing the driller to the area of the Schlems canal, to the we just pushed the pedal, and by doing so, and actually this is the end of the surgery after taking out the viscoelastic from the eye. So this is these two examples, the XEN and the MIMS, actually the two nice examples of ab internal procedures performed that are quite potent and gives us quite low pressure, at least at the beginning, not like the MIGS, but creates really blebs like trabeculectomy. Here in Hadassah, we also use the XEN in a different way in specific cases, putting it at the outside. We call it ab externer XEN implantation. So here we actually, by using a 30G needle, we create like a sclerotomy. And here you can use, you can see that we use the injector by putting the XEN at the outside. And now we'll zoom in and you see the XEN bulging like 2-3 millimeters at the sclera. And now actually by performing that, we close the conjunctiva with a tenon, and a nice bleb, a very diffuse bleb, will be performed in the following days. So this procedure also was done in this year with quite success. And you can see here the XEN bulging under the tenon, under the conjunctiva, straight and free, and waiting to be done. Before finishing, I want to go back to our slides. So we speak about the classical surgeries, the MPDS, XEN, and MIMS, and now I want to spend the last few minutes about the last implant that was approved in Israel only the last month, which is the PersoFlow. Very similar to the ab external XEN, but different. The PersoFlow is the implant that is built from a material that is called SIBS. The SIBS was first used in coronary stent coating. It's very flaccid, it's not rigid, it's a very non-rigid material, it's biocompatible, and as you can see, it's quite long. The length of this implant is about 8.5 millimeter, and longer than the XEN, and even the intraluminal diameter is larger, about 70 microns. And this is an example of the surgery that was done only 2 weeks ago here in Hadassah. We were one of the first centers in Israel to be trained using this implant to dipsorectomy or to trabeculectomy, performing a nice peritomia and cleaning thoroughly the conjunctiva with the tenon and cleaning the sclera. But unlike the trabeculectomy or deep sclerectomy, you can see by the way that I'm putting the mitomycin soaked sponges under the tenon, like 3 minutes. And unlike the trabeculectomy or MPDS that the next step will do to perform the flap, here, after taking out the sponges, the stent is supposed to be implanted. So 3 millimeter marked, and a short scleral tenon is performed by a special knife. And then the tunnel, the scleral tunnel, is completed using in 25G that is actually meant to penetrate the anterior chamber itself. At that point, the needle is bented deeply towards the iris plane. So to plan that the implant itself will be not close to the endothelium. So after performing this tunnel, the implant is applied and inserted to the scleral tunnel itself. And you can see that these two fins are plugged in and tucked in into the surgery is to verify the nice percolation of the tube. And by doing so, actually, after closing the conjunctiva and the tenon, covering this tube, the surgery ends. It's very, so actually the main part of performing the flap and the sclerotomy or a deep sclerectomy is actually bypassed by the implant, because the implants, the way it's in place, is controlled to maintain a nice pressure, not too low and not too high, after the surgery. In the last seconds, you can see, and this is the end of the surgery, closed title. Here you can see an intraoperative anterior segment OCT showing the location of the tube that is not too close to the endothelium, as you can see here. And this is the same patient 1 day after the surgery. You can see the intrascleral and subconjunctival pathway of the implant. And the patient had a 5 to 6 millimeter mercury with a deep chamber 1 day post-op. So just to summarize, not much progress in understanding the pathophysiology of glaucoma during the days, but many new players in glaucoma in terms of imaging, in terms of medical treatment, and of course, part of them are ab-internal surgery and part of them ab-external. And I'm so excited to share this information with you, because it's not just like a summary of the options and modalities of glaucoma, because now I'm so happy that in our department, all these procedures are available. So what was left for us as surgeons is to evaluate the specific patients and to tailor the best treatment for these options to needs.
Thank you very much, Dr. Greifman, for this great presentation of all the options and all the new stuff that we have right now in glaucoma, that we have really new tools for different options. And this is one of the questions from the audience is, how do you choose between them? How do you decide what are the main factors that you take under consideration when trying to choose one of the different approaches?
Okay, so this is actually the million-dollar question. First, we have to know the options. The second step, we have to practice them and to see the long-term results of each procedure. Now we know that some of the procedures are less potent. For example, iStent, it's a procedure that's available, but we know that it doesn't decrease the pressure dramatically. But other procedure like MPDS or maybe PerSaflow are much more potent and gives us much lower low pressure. So I suppose with time we will learn what are the pitfalls and what are the advantages and disadvantages of each procedure. But eventually, I think it's a matter of time. You know, first we have to understand for example, a patient that underwent ECC, okay, or endocapsular with a tunnel in the sclera. Every time I approach such a patient and I know that I have to perform a flap in a so sick the sclera, I'm puzzled. Now we have other options to have a very low pressure without performing a flap, like a gut procedure or like implanting this kind of stent or MIMS that perform a hole in the sclera with that is controlled hole or controlled passage. So especially in these places, this is an example how these types of procedures can help me tailor. Sometimes the end stage, the stage of the glaucoma damage will help me to choose which is more properly. But eventually, I think there is no one answer to what. That there is no specific procedure that is absolutely 100% for all patients, and we have to tailor. This is I think to be a glaucoma surgeon nowadays, it's not as it was like 10 years ago, that mainly two tools you had, either Trab or Ahmed. Now you have more modalities, you have gonio surgeries, you have several gonio surgeries, you have several bypassing TM, like trabeculectomy, MPDSS, like we mentioned. So I think the art will be to tailor for each patient is the best result of best procedure.
Okay, great. Another question from the audience is, traditionally, the CPC has been used for advanced glaucoma, for cases that have low vision, lost fixation, and many people were afraid to use it for glaucoma with no severe damage. And one of the questions is if we can use the micropulse CPC in eyes without significant glaucoma.
This is a very interesting remark, and this is also, we had a little bit of experience, because theoretically, because the profile, the complication file of MPs, MicroPulse CPC, is much lower. The standard 6 to 4 years used in a few cases, a very mild energy, and in a seeing eye, I just, if I remember, I had one patient that we performed a deep sclerectomy, and we did goniopuncture, and the pressure was like 22 after all the procedure, and we were not happy with the results because the target pressure was much lower. And this patient, and by the way, with two drops, the pressure was 14. So we asked patients, liked so much the fact that she will be medication free. So we asked, okay, let's try to do, addition with the micropulse. And the vision was very good. And we had to add some, addition to the IOP lowering effect. And we did a micropulse to her very cautiously with mild energy, and she's happy. Now the pressure is in target with no medication. So I think definitely during the time we will gain more experience and will be more confident to offer more and more patients this procedure, and not saving it to lost eyes or blind eyes. That was traditionally the options for these patients. So definitely, because it's low complications, offer it even to a seeing eye in a good visual acuity potential.
Okay, great. And one last question. It's a two-parter, because if you relate to the part that a lot of the problem with RNFL is in patients with PPA, for example, that you have a block, and now we have the ganglion cell axis. How do you think? Do you think that it has limitation? Any cases that you think that it's not up to par, or how do you think that it compares to RNFL?
Mm-hmm. So the new modality of the glaucoma modules, I found it very helpful in all these patients with borderline glaucoma that we're not sure if they have damage or not. So definitely in a patients that have, for example, peripapillary atrophy, all we know that the circumpapillary RNFL is not effective, because it to correlate, and we do it routinely now in the Hood report, because in every patient we actually compare the image of the RNFL to the real deficit of the RNFL and to the real deficit of the ganglion cells. So in many cases, we find it helpful. Unfortunately, in high myopic eyes, when they have very stretched retina and thin retina layers, sometimes the segmentation of the RNFL, of the macular RNFL, is also artifact, and we find ourselves puzzled without knowing the answer. But I think for many cases, not 100% of them, but in many cases, we find it very helpful as an addition tool to diagnose and to evaluate the severity of the damage.
Okay, so great. Thank you so much for this talk. I think it was a wonderful overview of all the new tools, and it gives us hope for treating glaucoma. And I want to move to the next talk, which is a little bit less optimistic, which is about glaucoma that is still underdiagnosed. I want to invite Dr. Yaniv Bar-Kana. He's a glaucoma specialist and a previous head of the Israeli Glaucoma Society, and a researcher in the field of glaucoma and Tel Shomer, and now he's in private practice. So please, Dr. Bar-Kana.
Okay, so good evening, everyone. Let me find my PowerPoint. Where is it? All right. Okay, so thank you, Gabi, for the invitation. I hope we can all stay awake until this is over. I'm going to speak just about one topic. It's too late for more than that. We heard from Gabi about many exciting developments in the diagnosis and treatment of glaucoma, medication, surgery, OCT. However, all these very exciting developments and tools that help us prevent blindness in our patients are irrelevant if neither the patient nor the ophthalmologist know that there is glaucoma. And unfortunately, this is more prevalent than you might suspect. And this is what I talked about. The title of my talk is taken from this paper published in 2015, which is actually a remake of an older paper, which shows that after a few decades, still the three reasons why people still go blind from glaucoma have not changed much. And the first one is that the glaucoma is still undiagnosed. Now, a more recent paper, October in Ophthalmology, is a review of several 20-something population studies, good, well-conducted population studies with good systematic diagnosis of glaucoma. And I think that you're not going to believe the numbers until you read them yourselves, but these are the numbers. So in 12 good population studies conducted in Europe, the rate of undiagnosed glaucoma was 67%, almost 68%. So 2/3, I repeat, 2/3 of patients with glaucoma in Europe, and that's, it shouldn't be too different in Israel, do not know that they have glaucoma. In North America, it wasn't much different. And in Africa and Asia, it was about 90%. So everything that we have, everything that we do is relevant to a small minority of patients with glaucoma. I think this is appalling. And the question is, how can we change this very bad situation? What can we do tomorrow morning to make this better? Now, some of you may be thinking, well, the government, the Kupat Cholim, the insurance companies, they should conduct good screening programs to find glaucoma. Well, ain't going to happen. It's still up to us. It's generally agreed by everyone that active screening for glaucoma is not efficient. It results in an unacceptably high number of false positive diagnoses, and this leads to an immense number of tests, visual field, and OCT, and expert glaucoma consultation, and this just swamps the system. So this is not going to happen. It's up to us every day in each of our patients to diagnose glaucoma, and this means obviously measuring the pressure, but much more important, looking at the disc. Now, so how does this look? You know, these bleak numbers that I've shown you, how do they look in everyday practice? So this is an example of a woman that complains of tearing. She goes to the doctor in Kupat Cholim. The doctor does measure high pressure, looks at the discs, and writes that the, pitmat kina, the disc is okay, and the CD ratio is 0.2, 0.3 in both eyes. So a diagnosis is made of glaucoma, suspect ocular hypertension, Xalatan is given. The patient is not happy because of the tearing, so she goes to another doctor. She had stopped the Xalatan after a few days because, she just has ocular hypertension and it was not convenient. And again, this doctor also writes a CD ratio of 0.2. Now, these are the discs, okay? And when you blow it up in good photographs, then it's not easy. It's not readily apparent, but maybe you can appreciate that the discs are different. So in the left disc, there's some bagel here. There's width of neuroretinal tissue. When the blood vessels reach the edge of the disc, they continue riding on this bagel of neuroretinal tissue and only then dip inside. Here, the blood vessels reach the edge of the disc and immediately dive into the disc. There is no width of neuroretinal rim here. If you look at the color, if you just look at the color, and obviously if you do it with undilated pupils and a plus-study lens, then you may, think that there is a very small central round cup here. But if you don't look at the color, and I suggest you never do from tomorrow morning, and you look at the contour of the blood vessels, then look, there's absolutely no width here. The vertical rim is almost full. There is some color here, yes. It's not like this color, but it's not neuroretinal rim, it's something else, it's connective tissue, whatever. Another example, a 4-year-old guy goes to the doctor complaining of bad vision in the right eye. Pressure is not measured. The fundus is takin, is healthy. He's not happy. This is the fundus. He's not happy. He goes to another doctor. This doctor does measure the pressure. It's 36. Here there's already cupping and notching and splinter hemorrhages and all kinds of things. Now, obviously, the discs are very, very different. But again, I want you to appreciate that if you look at the color difference, if you judge the cupping or the CD ratio, which as a number does not have too much meaning, but if you look at the color, then you can judge that there's a maybe 0.5, 0.6 cup here. But if you look at the blood vessels, again, here they ride on a very healthy rim and only then dive in. You can see it very clearly here. Whereas here, the blood vessels reach the edge of the disc, immediately dive in. So again, there is color here, but obviously, this is not the color that you see here in the healthy neural tissue. It's something else. It's connective tissue, it's dead neural tissue, whatever, but it's not healthy neuroretinal rim, and it should not be included when you assess the cupping. Maybe another example. Again, these things are not very simple, but I just want you to appreciate the difference between the very, very small central cup is judged by the color compared to the contour of the blood vessels, which again dive in just as they reach the edge of the disc without any width whatsoever of neuroretinal tissue. Of course, the best way to judge the topology or the topography of the optic nerve is with stereoscopic photographs and using these prismatic glasses, which you can buy at AliExpress for $1. all the cameras have this function of stereoscopic photos. All right, here's a striking example of how discs are viewed by many, many ophthalmologists and how glaucoma is missed. So I think if we look at these discs, most of us, including myself, on cursory exam, looking with undilated pupils, looking with a +90 lens, we would say that there's a central, round, healthy cup. Blown up, zoomed in good photographs, then again, it's not easy, but you can appreciate that at the superior disc in both eyes, there's a very nice healthy rim. There's a very clear width on which the blood vessels ride before they dive in to the cup. Whereas inferiorly, not so much. Now, it's very subtle, but you can appreciate that this color is not the same as this color. It's much more faint. The blood vessels dives in just when it reaches the edge of the optic disc. If you want, there's a disc hemorrhage here. Now, in my clinic, before, the first thing I see when I go into the software of this camera, which is very user-friendly, is not such a zoomed-in photograph of the disc. It's the whole fundus. And in this photo, the most striking feature is not at the disc. It's outside of the disc. And it's the classic bundle defect of the RNFL that we heard about when we were studying for exams, but we've never seen in at the slit lamp. So maybe you can, I hope you can appreciate that superiorly, there is these white striations of healthy RNFL in the right eye also, whereas inferiorly, there's a striking lack, focal lack of these striations. Here, there's white striations. Here, it is not, it's clear. And here also. And I've highlighted it here if you didn't see it before. And if you really want, then there's another less clear bundle defect here and another disc hemorrhage here. So, most ophthalmologists looking at these discs on cursory examination would miss the diagnosis of glaucoma. But if you use these kind of photographs, these kind of cameras, then you start making the diagnosis better. What can I say? Now, if I need to, we are in academics, so if I need to take to use some published reference to convince you that using photographs is better than just looking at the fundus, then there is this very famous paper from the ocular hypertension treatment study, a few thousand eyes followed for about 8 years, and they looked for disc hemorrhages. There were 128 cases of disc hemorrhages. Every year, these patients would be examined with dilated funduscopy, dilated pupils, and stereoscopic disc photographs. And it turned out that the vast majority of disc hemorrhages were diagnosed only on photographs. A small minority were diagnosed by looking at the fundus. Now, these are not like us, busy ophthalmologists doing general clinic. These were academic centers specifically trained to participate in the ocular hypertension treatment study. And the investigators were specifically instructed to look for optic disc hemorrhages. And yet, still, most of the disc hemorrhages were missed on clinical examination with dilated pupils. So I think, yes, looking at photographs where the patient is not tearing and is not suffering the light and the mask is not interfering, and you can zoom in and look at your leisure, I think it makes a difference, a big difference. All right, a few more examples. Many of us may think there's nothing wrong with this disc. Looking more closely, maybe it starts to, this is not a clear photo, some of the photos, these are undilated pupils and some patients have cataracts. but maybe you can appreciate that there is some striations down here. There's a focal lack of striation here. When you get used to it, it starts jumping into your eyes. You know, there's white striations here and here, but here there's a bundle defect. There's thinning of the rim here with the blood vessels, again, diving in immediately as they reach the disc. All these cameras have filters which help highlight these bundle defects. So striations here and a black lack of striations here. Is it important? Of course it's important. That's the visual field of this patient. There's a significant defect here. And so it's very important to diagnose and treat this patient accordingly. When you start, photographing all these patients, you see eyes with two disc hemorrhages here and here. So just a minute, I don't see my own slide, but so a friend of mine recently calls me and tells me that they told him he has a glaucoma, if I can see him. So I see him, and he has a textbook photograph of glaucoma. I hope you can appreciate in both eyes that there's a superior and inferior bundle defect here in the superior and inferior bundle defect. The disc hemorrhages here. So much information, so much visual information, and very, classic and pathognomonic visual information outside the disc that makes us help us make the diagnosis of glaucoma. So just a few more photos. Here, a very large bundle defect. It's highlighted in the filtering. Again, very clear striations, very clear lack of striations. Here highlighted with the filter. And recently, as Gabi has also mentioned, this is a top con, but the OCT companies have started including on-fast photograph, so you can appreciate the bundle defects. Sometimes it's difficult to pick up on the OCT, and this is clear here, but sometimes there's so much noise and you don't understand exactly what you see on the OCT. So this is just a nice photograph that they include. And to conclude, I would like to say that the photography of the RNFL, which is so clear, you can appreciate the striations here and here. It helps us in the opposite spectrum of glaucoma diagnosis. So many patients come to you and to me, and they have large cups, and so they become glaucoma suspects. And sometimes they are treated, sometimes they are followed aggressively. But in my clinic, before they open the door, the technician takes the photo, and I see it before they enter my room even. And when I see such healthy striations, both superiorly and inferiorly, and temporally, nasally, and there's no hint even of a bundle defect, obviously there's a full field, then I can be much more confident that this is a healthy disc, and that follow-up can be pretty much routine. I have absolutely no financial interest in all of this, but this is one of the cameras that can be used to produce very easily photographs like the ones I've shown. It costs 70,000 shekels. So, we can continue to do what we are doing, knowing that more than half of cases with glaucoma remain undiagnosed, and we can try to make a change by buying such cameras and using them more frequently. And then maybe we can make these awful numbers just somewhat less awful. Thank you.
Thank you, Dr. Balkana, for this really, really important talk. I think that you hit one of the main obstacles that we have with glaucoma, that people come too late when they're already counting fingers, and then you look at them and you say, what if you have only come a few years back when you had some vision and we could have helped you more?
Yes,
what are you presenting?
and then they say, but doctor, I did have something, an examination a few years ago. They didn't tell me anything.
Right, exactly. And what you're presenting is a way of sort of telemedicine, that you see the pictures and then you analyze them. How do you think AI, which is a really hot topic right now, is gonna join this effort and be intertwined into this topic?
Well, first of all, tomorrow morning we can use these kind of cameras with our own intelligence before the AI is approved. Of course, there is an FDA-approved software to diagnose diabetic retinopathy. And it's only a question of time before this extends to glaucoma. It's not there yet, but it will get there. And until it does, it's up to us. It's up to us to diagnose these cases and not miss cases, as apparently we continue to do, because there's so many undiagnosed cases. And I'm a glaucoma specialist, so for me, this camera changed my whole, professional activity, because really before this, when I start working with these photos, then not only is it more convenient and you can compare them, after 1 year, etc., but these hemorrhages and RNFL bundle defects were not a routine part of my clinical practice before this. Now it's every day. It's every hour sometimes, and it really makes the diagnosis much more powerful. Both making the diagnosis of glaucoma, following glaucoma, and making the diagnosis of not having glaucoma, also important. So I think it's readily available. It's not extremely expensive, and I think it can make a big difference. Now, before AI, telemedicine is something else. A technician takes these photographs, and the doctor can be anywhere, and he can see them, or she can see them at her convenience. At Shari Tzedek, there's such a camera, and they have an active screening program for glaucoma. So we can do all of these things different than we used to do, just looking at the slit lamp, and make more diagnosis.
And you think, like you said, the problem is when people, you said like you got the picture of your friend that had a really advanced cup, and this was easy to see. Like, I think that most doctors won't miss a total cup, but the earlier stages are the most important one, because then you can be more active and prevent loss. And I think that this is where most doctors fail. If the 0.4, the 0.5, 6, where is the cutoff? So what is your position in this, and what's your tips and assessment for this kind of?
Well, there's a Shlav Bet coming up.
Mm-hmm.
So when I sit with the guys studying for Shlav Bet, I tell them, forget about CD ratio. It's almost meaningless. Even if the same person needs to grade a CD ratio, it can be very different 5 minutes apart. So in glaucoma, the hallmark of optic disc pathology is focal notching, focal thinning of the rim. That's what you're looking for. Not the CD ratio of 0.9 or 0.4 is meaningless. A CD ratio of 0.8 If the rim is healthy, there is no notching, and there's a large disc, then the patient is healthy. So the number itself is pretty much meaningless. The hallmark, what you should be looking for, is focal thinning of the rim. It's better to do it looking at the contour of the blood vessels and not at the color of the cup. And again, the RNFL bundle defect, when they're so beautifully imaged by the camera, are extremely helpful. And disc hemorrhages also, objective, clear, pathognomonic RNFL, at least. Disc hemorrhages, there are different reasons, but very helpful anatomic landmarks to make the diagnosis of glaucoma, to help you make the diagnosis of glaucoma. And again, even looking at the disc, if you can sit leisurely at the computer and look at the disc without the patient blinking, and you can zoom in the photograph and you can look at it stereoscopically, then it's not the same as using a +90 lens and looking through undilated pupils at the slit lamp. It's just not the same.
And how do you involve when you look at the pictures? You look at the pictures, but you don't get information, other information that you need. You need the angle, you need the pressure, you need the entire picture, and not all the time you're gonna get it. Even if you can assess for suspicion for glaucoma, you won't assess for the urgency of treatment.
I'm talking about a scenario of a regular clinic. The patient comes in, everything is regular. Just I'm not looking at the slit lamp at the fundus, but I have these photographs. But everything else I do the same. I examine the patient according to whatever is needed. If you're talking about a remote diagnosis, then you're correct. But again, it's better than nothing.
Yeah.
But
another question from
it's just part of
from your routine.
Of my clinic setup.
Mm-hmm. And in regards to that, one of the attendees asks, how do you address disc hemorrhages in patients with normal tension glaucoma when the pressure is around 10? If you have a patient with normal tension glaucoma, pressure of about 10, and you have active, you see a disc hemorrhage, how would you address that?
Listen, we don't have time to discuss this, but there has been, more and more literature on the predictive value of disc hemorrhages. When it's part of glaucoma, it tends to signify active disease, and you should probably upgrade your treatment. However, of course, in glaucoma, the goal is to preserve vision. And in order to do this, you need to follow with visual fields. And this is the ultimate decision-making parameter. So if the visual field has been stable and the pressure is 10, it's very difficult to lower a pressure of 10 even with surgery. And if there's a disc hemorrhage, I will repeat the visual field sooner than I intended to. And visual field, there's no progression, there's no worsening, then there's no need to upgrade the treatment. And if there are signs that maybe things are getting worse, then it's time to upgrade treatment, even if it means surgery.
Okay, another question is, how is the IK camera different to other fundus camera regarding optic disc or fundus photography?
I will repeat again that I have absolutely no financial interest in all of this. I'm just very, very happy with my camera and very, very happy to share with you how happy I am with my camera. So there's this line of cameras, they have a few models out by the company that is called Centerview. It's now iCare bought Centerview. And these cameras are fundamentally different than all other cameras. All the cameras that you know use white light. And these cameras use a confocal laser which uses white light. I don't understand physically how it works, but the fact that they use a confocal laser makes the resolution of the photographs higher. And so this is one of the reasons why RNFL bundle defects were not a part of our clinical routine. I mean, even glaucoma specialists, we're not used to seeing RNFL bundle defects on fundus photographs. And with these types of cameras, which by the way, it's only by this company because they have a patent on it. So there's no competing company. But with these kind of cameras, as I said, it's part of my daily routine.
Great. So thank you very much. I think that both talks were really good in showing the advancement of glaucoma and how we are still stuck in the past and trying to advance and help people. A few messages for the end. I think that if you have any patients that have been that can fit to one of those topics that we showed you today, for example, we have the vertigo and nystagmus clinic by Dr. Ali Shemesh. You are more than welcome to refer. Of course, we will continue with our meetings, and all of you are welcome to join. For example, for our Zoom tomorrow, we have our department's grand round, and it's going to talk about strabism surgery for sensory exotropia and also gene therapy for Leber's hereditary optic neuropathy. So you are more than welcome to join us. And of course, if you have interesting cases, we are in neuro-ophthalmology or glaucoma. We will be more than happy for your referrals. That's it for today. So thank you very much, all of you, for joining, and thank you for the great talks, and good night, everybody.